Today I want to talk to you about recognizing and treating myocardial infarction. Let me do a quick review of the coronary blood flow. Both the right and left coronary arteries come off the ascending aorta as the aorta leaves the left ventricle. The left coronary gives off the left anterior descending and the circumflex coronary arteries. The right coronary descends the anterior surface of the heart and gives off the right marginal artery. The right coronary artery swings posteriorly and gives off the posterior descending artery. Here is the picture of the electrical conduction. Electrical impulse spreads from the sinus node throughout the left and right atria, causing the atria to contract and expel its volume of blood into the ventricles. The electrical impulse spread from the bundle branch throughout the left and right ventricles, which causes the ventricles to contract, forcing them to expel their volume of blood out into the general circulation. What are the common symptoms of a heart attack? Chest pain, chest tightness and heaviness, extreme fatigue, a sense of unusual or extreme tiredness that lasts for days or weeks can be a sign of heart trouble. This symptom can be more common in women. Fainting and lightheadedness can be very common. Pain in the shoulder, neck, or jaw can be experienced, and shortness of breath with or without chest pain. Persons may have sweating, nausea, or vomiting. Epigastric abdominal pain can occur in the elderly. Diabetic patients, women, and post-op patients may have an atypical presentation of cardiac chest pain, including no pain. Please remember that the most common sign of a heart attack for both men and women is chest pain. Every 42 seconds, someone in the United States suffers a heart attack. Myocardial infarction may be classified as posterior, anterior, inferior, lateral, and septal. If indeed it's a true MI, then there will be reciprocal changes. The acronym PAILS, P-A-I-L-S, has been, the mnemonic rather, has been coined to help us understand this. If there is posterior ST elevation, then there will be anterior reciprocal changes. If there is anterior ST elevation, there will be inferior reciprocal changes. If there is inferior ST elevation, there will be lateral reciprocal changes. If there's lateral ST elevation, there will be septal or inferior reciprocal changes. And if there is septal ST elevation, there will be posterior reciprocal changes. Let's talk about anterior wall MI. ST segment elevation or Q waves in one or more of the precordial leads, namely V1 to V6, and lead 1 and AVL has traditionally been used to suggest anterior wall ischemia or infarction. Patients presenting with an anterior wall MI usually have occlusion of the left anterior descending coronary, the presence of ST elevation in lead AVR, complete right bundle branch block, ST depression in lead V5 and or ST elevation in V1 greater than 2.5 millimeter strongly predicts a lateral left anterior descending artery occlusion. Take a look at this EKG. There are a few things to take note of. Number one, there is poor R wave progression in lead V1 to V3. Number two, there is ST elevation in lead V2 to V4. And number three, there is T wave inversion in lead 1 AVL and V2 to V5. Inferior wall and right ventricular MI. ST segment shifts or Q waves in leads 2, 3, and AVF suggest inferior wall ischemia or infarction. If there is evidence of inferior wall ischemia, right-sided leads, especially V3R and V4R, should be obtained to assess for a possible right ventricular ischemia or infarction. Take a look at this EKG. Notice a few things on this EKG. Number one, there is ST elevation in leads 2, 3, and AVF. Number two, there is ST depression in the lateral leads, namely lead 1 and AVL. And number three, there are ST elevations in V4R and V6R. This is a true right ventricular infarct. Posterior wall MI. Acute posterior wall MI induces ST elevations in leads placed over the back of the heart. Example, leads 7 through 9. This is usually associated with reciprocal ST segment depression in leads V1 to V2, V3, or V4. Posterior inferior wall MI can usually be differentiated from anterior wall ischemia by the presence of ST segment elevation in the inferior leads, namely 2, 3, and AVF, in addition to posterior leads V7 to V9. Relatively tall R waves may also appear in leads 1 to V3, in lead V1 to V3, corresponding to the appearance of pathologic Q waves, which is the loss of depolarization forces in the posterior leads. Take a look at this EKG. A few things to note. Number one, the posterior leads V7, 8, and 9 are placed to the back of the heart. Number two, there are ST elevations in leads V7 through V9. Number three, there are ST elevations in leads 2 and AVF. And lastly, true posterior MI will show ST depression, T wave elevation in V1 to V2, Q waves, and ST elevation in V7 and V9. The lateral wall MI. ST elevation in leads 1 and AVL is characteristic of acute lateral wall infarct. Reciprocal ST depression is evident in this case in the inferior leads 2, 3, and AVF, and in V1. Pattern recognition. Delayed and abnormal activation of the left ventricular myocardium and the diffuse slowing of conduction throughout the left ventricle leads to the following changes on the ECG. There is a tall, monophasic, and broadened R wave in leads 1, AVL, and V6 instead of a septal Q wave. There is a QS complex which is abnormal and widened in V1 instead of a small initial R wave due to septal activation. The QRS interval is prolonged greater than 0.12 seconds. Myocardial repolarization changes including T wave inversion and ST depression are evident. Let's talk about the treatment. Oxygen is no longer recommended routinely for non-hypoxic patients with STEMI because it may increase coronary vascular resistance. Now that we have identified the MI, how do we treat? Aspirin has the greatest benefit in reducing morbidity and mortality. Beta blockers reduce myocardial oxygen demand by decreasing heart rate, inotropy, and blood pressure. All patients should get beta blocker in the first 24 hours, even if they are scheduled for PCI and fibrinolytics. Nitroglycerin reduces left ventricular preload and increases coronary artery blood flow. For the patient with normal blood pressure who is in pain, nitroglycerin can be administered sublingually in the pre-hospital setting at a dose of 0.4 milligrams every 5 minutes until pain is relieved, with a maximum of 3 doses. Fibrinolysis and PCI are the 2 rapid treatment options for STEMI. The P2Y12 inhibitors, including the clopidogrel, the prasugrel, and the ticagrelol, bind adenosine phosphate platelet receptors to inhibit platelet activation and aggregation. Prasugrel is contraindicated in patients with a history of stroke or transient ischemic attacks and did not show benefit in patients older than 75. Heparin and anticoagulation therapy are recommended for STEMI with patients with planned primary PCI. Unfractionated heparin is recommended. You may start between 70 and 100 units per kg with IV bolus without the GP2B3A receptor antagonist. And by the way, the 2B3A antagonist is aggrastat. Or 50 to 70 units per kg IV bolus if given with the GP2B3A receptor antagonist. Again, it's aggrastat. STEMI patients who primarily receive fibrinolytic therapy should receive anticoagulant therapy for a minimum of 48 hours. Unfractionated heparin as a weight-based bolus and a subsequent infusion is recommended. Percutaneous coronary intervention, PCI. When PCI is readily available, the guidelines recommend that primary PCI be performed in STEMI patients with symptoms less than 12 hours in duration. Between 12 hours and 24 hours, PCI is reasonable if there is clinical or ECG evidence of ongoing ischemia. PCI is further recommended for patients with cardiogenic shock or severe acute heart failure, regardless of time of STEMI onset. Thrombolytics. Thrombolytics, although randomized clinical trials have shown that primary PCI is superior to fibrinolysis in reducing mortality, reinfarction, and stroke, it may not be available as an immediate reperfusion option. Fibrinolysis must be considered when patients present to a center without a PCI program in places that do not have 24-hour catheterization laboratory coverage, or when other delays to getting a patient to a catheterization laboratory exist. The 4 fibrinolytic agents available are tenecteplase, retiplase, altiplase, and streptokinase. Altiplase, if it is used, if the patient weighs 6 or 7 kilos or less, then the first dose could be given at 15 milligrams IV bolus. The second dose is given at 0.75 milligrams per kg over 30 minutes for a maximum of 50 milligrams. The third dose is given at 0.5 milligrams per kg over 60 minutes with a maximum dose of 35 milligrams. If the patient weighs over 6 to 7 kilograms, the doses may be given at 15, 50, and 35 over the same time period. Transfer of STEMI patients to a PCI center. STEMI patients should be transferred to a PCI center as soon as possible to reduce major adverse cardiac events. The primary focus is on developing streamlined systems to transfer STEMI patients directly to a PCI-capable facility. For STEMI patients presenting to a non-PCI center, transfer to a PCI center is recommended if door-to-device time can be accomplished in 2 hours. If not, fibrinolysis should be considered. Transfer to a PCI-capable center is recommended once fibrinolysis is instituted. Angiography can then be performed at the receiving hospital as soon as feasible, preferably within 24 hours, but not within 2 to 3 hours after fibrinolytics were given. Well, thanks for watching. Some of the content in this presentation came from Emergency Medicine Practice and Up to Date. I encourage you to subscribe to both publications and stay current in your practice. Don't forget to like, share, and subscribe. I wish you well. Good night.